I'm a physicist at Duke University in Durham, North Carolina. And I'm happy to be talking to you today about radiation therapy treatment delivery. So you've had a long course covering many details about radiation therapy for 3D conformal radiation therapy in particular. So treatment delivery is the culmination of this whole process you've been going over in this course. So we've gone over many different concepts, and now is the time we want to ensure that all of these preceding steps leading up to treatment result in safe, accurate, and effective treatment for the patient. So all of these prior steps that have been covered, simulation, contouring, planning, dose calculations, all of this is leading to effective treatment for our patients. So I have several points I'll touch on during this presentation. It's broken down into 8 different sections. We'll go over pre-treatment QA, things that are done leading up to treatment to make safe treatment, patient identification, setup and immobilization, imaging and applying shifts, timeouts, real-time monitoring during treatment, how to handle treatment interruptions, and then ongoing QA and incident reporting. So we'll start with pre-treatment QA and safety checks. So before we even get to patient treatment, we want to minimize the potential for any incidents or errors during the patient treatment. So a lot of practices are put into place ahead of treatment before the patient comes to make sure that treatment will be safe and effective. So this can start way back, even earlier than what I've mentioned here, with good commissioning and development of your program management. But main things I'll touch on would be plan review. So making sure that the plan is a high quality plan. We've had contour review, peer review by other physicians, chart rounds, physicist review, all of those things. MU verification, a secondary check on the MU, as Dr. Wadi Ramahi covered last week. And then patient-specific QA if you're doing IMRT or VMAT, or maybe you have customized calculations for that patient for electron cutouts, for example. But the 2 main things I want to emphasize are the physics initial chart check and the therapist initial chart check, both of these occurring before treatment starts. So there's a lot that goes into a physics initial chart check. It's hard to fit all of the details on one slide, but 2 great references to look at for plan and chart reviews are in AAPM Task Group 275, and then also in the Medical Physics Practice Guideline 11A. So these give a lot of information about what's included in physics chart review and different checklists you might consider, different components you might consider when establishing policies at your site. And so some of the checklist items are going to change when moving from 2D to 3D. You're going to be adding in additional checks in your physics review process. So as I mentioned, these lists are very long. There's a lot of different components included. I'm just going to highlight a few of these, but they're coming from this MPPG 11A. So I'll show you on the next slide just a highlighted few. So again, these are some of the key elements of the physics initial chart check. So we have 2 main categories: checking for plan integrity, making sure you have a high quality treatment plan, and then checking for preparation for treatment, making sure that the plan is ready for treatment delivery on the treatment machine. So plan integrity checks are going to include things like the patient's name, medical record number, date of birth, making sure that our prescription matches the plan, the ISO center is appropriate and documented properly for treatment. We have appropriate field setup, dose calculations, and dose metrics. We have a good evaluation of the DVH. The correct planning CT is used. This is a very big one. You want to make sure that all of the calculations were performed on the right image set and that we're using the right setup for treatment. And then any kind of clearance or couch issues or treatment devices or accessories. And then making sure a secondary dose calculation difference is less than 5%. So all of that is going into plan integrity, and then we make sure that the plan is ready for treatment as well. So we want to make sure the plan and prescription are approved by the radiation oncologist. All of the parameters are input correctly. You might have different checks depending on if the parameters have to be transferred through a different system or a different vendor, making sure those interfaces are working properly. We want clear and consistent setup instructions. We want reference images selected and defined properly. tolerance tables assigned, any kind of imaging alignment instructions, and then making sure we have the treatment schedule set up correctly and proper reference point dose tracking. So these are just some of the elements, but it gives you an idea for what types of things we're checking during the physics and initial chart check. And these should be customized based on your workflow and what kind of equipment and software you're using, thinking about where errors are likely to occur and where we need extra attention and validation. In addition to physics initial chart checks, it's important to have therapists checking charts before patients arrive for treatment, making sure that they're familiar with the plan and performing pre-treatment chart checks, making sure all of the accessories are available, treatment mobilization devices, all of those things. And so here you see another long detailed list of things to consider when you're building your therapist initial chart check lists. There's going to be some overlap with the physics chart check items. Not all of the things will overlap, but some of the critical ones will when it's important for more than one person to check in case critical errors might make it through. But mainly we're wanting to confirm that the critical information is available, approved, and consistent before patient treatment. Therapists also have additional considerations if they're involved with treatment scheduling, making sure the patient is scheduled properly on the correct machine, and then potentially things like billing related checklist items as well. So here's an example of a therapist initial chart checklist that we have at our institution. This would be customized for your clinic and your workflow, but there's some items on this checklist that are done pre-treatment, so before the patient comes, and some that are done during the first day timeout for treatment. And so you can kind of combine these into one form or have separate forms as well. And then on additional pages, we leave room for photos. Photos are very helpful for documenting the patient's treatment position. And so you'd want a picture that shows any immobilization devices used for treatment, setup marks on the patient, and documenting where isocenter is. And then we can also fill in SSD information, confirmation of the setup by the physician, and which therapists were involved in treatment. So this is how we handle our therapist initial chart check documentation at my site, but this would be customized depending on your software and your workflow. All right, so all of that is stuff that happens before treatment, before we bring the patient back to the machine. So we're well prepared to have a safe and accurate patient treatment delivery. Now we're moving into the patient actually showing up for treatment. And so the very first thing we want to do is properly identify the patient. Make sure we have the proper patient for treatment. So this is an example of an error that can happen. So there were two patients that had the same first name and last name, but they had different middle initials. So it was a very subtle difference in name, and they were both being treated for prostate cancer. So one of the patients had already started their boost treatment, and he was called into the treatment machine and set up using the incorrect parameters. So he had a full field treatment instead of a boost treatment. And so the technologist team, the therapist, had just changed and were not informed that there was a problem with two patients with similar names. And so I put examples here of ways we can make alerts with the stickers or alerts in your electronic system showing that we have two patients with very similar names and to pay extra close attention. So regardless if your patients have similar names or not, we need to have a procedure for timing out and identifying the patient prior to treatment each day. So this is an example of a policy, pretty basic policy here. So prior to each administration or radiation treatment, the patient's identity is verified by more than one method. So for outpatients, patients who are just coming for treatment and leaving again, we verify their name and date of birth. And for patients who are staying in the hospital, in-house patients, they have ID bracelets that we can use for identification. And so their bracelet would stay on them while they're in the hospital and have their name, date of birth, and medical record number. So that's one example of what types of information are checked and how to put that into a policy. But this ID check should be performed each day and should be documented. So somewhere somebody should be signing off that indeed they did check the patient's identity that day. And while patient photos are helpful, they do not replace an ID check. It can be helpful to see the patient's photo when you go to gather the patient from the waiting area, bring them in, make sure they look similar to what you're expecting. It can help you identify them, but you still need to use 2 independent identifiers like the name, ID number, or date of birth. And then make sure, again, to have alerts for patients if you notice that they have similar names. It can help everyone to pay extra close attention for those patients. So here's just a picture of an automated option. Some hospitals have ID cards. We don't have this at my hospital, but it's an example of what can be done with a specific barcode for each patient, their picture. And then the patient could come and scan their ID card with a barcode scanner each day. So that's an automated option where you actually have your own card and can check in for treatment each day. And that will allow the therapist to open the chart on the treatment machine. So that brings us to our first Zoom poll question. The following is a helpful question for verifying patient identity. Occupation, date of birth, or referring doctor. We have a few seconds left.
Yeah, well, a few seconds left. I see people are busy chipping in their options. So, in the next 1, 2, 3, 4, 5. Okay.
All right, so it looks like 90% of the respondents got it right. We'd want to use the date of birth. So knowing the patient's occupation and referring doctor might be helpful, but several patients could have the same occupation. They could be referred by the same doctor, so that wouldn't be a way to identify them from each other. So we'd want to use things like name, medical record number, and date of birth that are specific to that person. All right, we'll move into the next section about setup and immobilization. So it's very important, you saw during your simulation presentation that setup must be clearly documented at the time of simulation. There might be additional notes added during planning if you're adding bolus or changing the setup slightly from how it was simulated, but all of these things need to be recorded and communicated clearly for treatment. One way to help with this is standardizing your setup instructions. So making sure that everyone who's writing down setup notes is using the same order for instructions, same names for devices, same abbreviations, etc. So then no matter who's writing the notes, it has the same format and everyone knows what those abbreviations mean and will recognize them when it's time for treatment. If possible, it's helpful to refer to the same document during treatment that was filled out at setup to minimize errors from copying and pasting. But if you are using copy and paste to put the setup information in for treatment, it's really important that these notes are checked by physicists and therapists during their initial chart checks. And again, photos can be very helpful. As we say, photos are worth 1,000 words. Seeing the actual patient setup in a photo can be very helpful for the therapist to verify that the positioning is the same as it was for simulation during treatment. So here are some pictures of patient-specific immobilization devices. We'd want these to be clearly labeled for each patient so we know which one to use for each patient. Again, be careful if you have patients with similar names. And you want to mark positioning of the device relative to the patient. So if you have isocenter or reference marks labeled on your patient, you want marks on the device as well so you know where the patient should fit within your device. If you have shared or adjustable devices, such as this one with many different parts that can be moved, you want to make sure the instructions are documented clearly for each patient so you know where to position each of these movable parts for each patient, since they might change from treatment to treatment if they're shared between patients. And here again is where standardized information is important. You could have, shorthand notations for these positions like H5, B6, depending on which part of the device you're referring to. Everyone should know what that means. Setup positions must be communicated clearly. So we want to clearly define marks on the patient for setup. And so at the time of simulation, I know you covered this during your simulation presentation, We want to have reference points on the patient, 3 points for setup, making sure the patient's level before aligning them to isocenter. So we want these marks to be clear on the patient, and having photos of where these marks are located is very helpful, especially if the marks might be lost prior to treatment. You can try to get them close to their original position. Measurements can also be helpful for this. And then when we have shifts to treatment isocenter, those should be clearly documented for treatment. So here's an example of how we write shifts. So CT0 is our reference marks, our reference point location that we established at simulation, and then we shift from there to isocenter for treatment. But there are different ways to communicate this information. You can see here's an example from a treatment planning document. In this case, they say move the table left, but they say looking from foot of table. So you can see there's a difference between these two ways of describing the shifts. And you want to be clear if you're referring to patient left or therapist left. Whose frame of reference are we using? So when you're communicating setup shifts, it's very important to make sure the planners, the physicists, and the therapists are all using the same frame of reference to communicate. Everyone should know if we say left, if that means patient left or therapist left. We also want to check clearance of the gantry around the patient to prevent injury to the patient or damage to any of the mobilization devices or the treatment table. These things, clearance can be estimated from your treatment planning system during the planning procedure. And we can also check before the patient comes if we have their mobilization devices, we know the table position, can set those things up to check for collisions with the table and the mobilization devices prior to treatment. But when the patient comes, we always need to verify clearance with the patient in their final position prior to rotating the gantry remotely for imaging or for treatment. And if you set the patient up, you check rotation, but then you apply shifts during imaging, you'll want to check again if you had tight clearance on any of your gantry angles. So the reason we do these clearance checks, the first priority obviously is to prevent injury to the patient. We definitely don't want to be having a collision with the patient, but we also want to avoid issues with partial treatment. If we realize that there's a collision issue after a portion of the treatment is delivered, then we have to figure out how to compensate for partial treatment. So knowing ahead of time before we treat any of the fields, if all of the fields will clear, is very important for that reason as well.
Yeah, Julie, I think this is a very, very important aspect because I remember very much in 2016 at our center, by then we had one functional machine, and I remember it was a Cobalt 60 machine. And due to this, actually not checking for the clearance before turning the gantry, I remember there was that some sort of tool on which you could step on before you get to the couch. So the gantry crashed into that stool and the machine broke down for literally the entire year. It went all over the news.
Oh,
So
wow.
this is something very, very important to look out for. And yeah, I highly agree to this. Thank you.
Thank you for sharing that. That's an important point too. Not only the gantry rotation around the patient, but if you have other things in the room that could collide as well, you want to make sure that the whole area is clear for the gantry and for the couch if you end up wanting to rotate the treatment table as well. That's very important. That actually happened at one of our sites too, where one of my colleagues was shorter, and so he'd bring in a little step stool to look at, SSDs or alignment. And when the gantry rotated down, it cracked the collimator housing. So this can happen to anybody, anywhere, and it can be really serious for machine repair, if not for patient injury. So thank you for pointing that out.
Yeah, and there is a question in the chat box. Lawrence is asking, how is clearance estimated using the TPS?
So if you know what the distance is from isocenter to the gantry, you can measure using a digital measuring tool in the treatment planning system. You can measure from isocenter to, whatever that distance is. It's like about 40 centimeters for us, for our machine. And so you can measure 40 centimeters around isocenter and see if the gantry is likely to collide with the patient or table or mobilization device. Some treatment planning systems have software checks that can do this as well, where it estimates the gantry position and can show you where collisions might be occurring. But one warning with those is that it will only capture what was included in your CT scan. So a lot of times when we acquire a CT, it might not include like the patient's elbows, for example. If they're out to the side, we might have only scanned part of the arm. And so you still want to verify when they come for treatment that the gantry will clear around, because you may not have included the entire extent of a patient's arms or immobilization devices. But yeah, just measuring, knowing what your distance is, your offset. So that's something you can measure on your machine, see what that distance from isocenter to the gantry is, and then also using software tools if they're available. Okay, so now moving on to pre-treatment imaging and applying shifts. So after positioning the patient for treatment using our setup instructions from simulation and applying any planned shifts to isocenter, we then verify isocenter using imaging. So there's multiple reasons to acquire images for 3D conformal radiation therapy. Some of them are noted here. So first of all, we want to verify our isocenter location. This can be done with MV, KV, or cone beam imaging techniques. We also want to verify and document our treatment portals and field shape. This can be done with your MV treatment beam. And we want to verify our target and normal tissue alignment. So we want to make use of all of the OAR sparing that we developed in our plan and make sure that we're treating our target with its reduced margins that we have in 3D CRT. And so we can achieve this with MV, KV, and cone beam imaging. Those are all options for verifying target and normal tissue alignment, just depending on what you're treating. We don't need to use all of these techniques for each of the treatment sites. I'm saying that they could be accomplished with these different techniques depending on your treatment site. So to align the patient for treatment, the acquired images are compared to reference images, DRRs, or digitally reconstructed radiographs. So this is like the X-ray image that you get from your planning system. And then shifts may be performed to fine-tune the patient position based on imaging. So it's important to note that on our first day of treatment, you're going to want to acquire all of the images prior to treatment to avoid shifting between fields. So you wouldn't just want to image your AP field and treat, and then go to your lateral field and realize that your vert was offset and you needed to make a correction. You want to apply all of the shifts that are necessary prior to delivering any of the treatment fields. So we'd want to image all of the field angles prior to starting treatment. And then I put a note here to have special care for matched field borders. If we have a case where we're matching fields and we have a match line that needs to be maintained, you want to be careful to maintain that match line and not apply shifts between fields that are going to cause dose overlap. So sometimes it's better to have a little bit of patient misalignment, but maintain that match line rather than shifting into your other treatment field. So if you're going to be matching field borders, again, important to image both fields first before delivering one of the treatments and making sure that match line can be maintained. So policies for applying shifts should be developed for each treatment technique and site. You might have different goals for different treatment sites, knowing what you want to match to. So these orders come from the physician deciding if you want to match to bony anatomy, soft tissue, fiducials if the patient has some sort of internal marker, and then knowing when you're required to re-image. So at my site, we have rules for when we need to re-image prior to treatment. If we have larger than expected shifts, for example, we re-image again to make sure that after the shifts are applied, everything looks appropriate. And then how often to acquire images, knowing if the physician wants imaging performed daily, weekly, and then what to do if you have large shifts when you are acquiring images. Do you need to repeat the imaging the next day to verify that the setup is consistent? So we have rules for all of those things as well. So it's really important for each site to think through their policies based on what treatment sites they're treating and what type of matching they're doing, whether it's bony anatomy or soft tissue. Oops. There are some additional methods to confirm patient positioning. So after verifying our patient position with portal images, typically at our center, we mark the isocenter location on the patient. And so that marking can be used for setup on subsequent days. And then we also outline the field shape on the patient's skin or treatment mask for our 3D fields. And so we'd actually trace the field on the patient's skin to help for extra verification too when they come back on subsequent days. And then we record SSDs, the source to surface distance, and we compare to the planned value and alert physics if the difference is greater than an established threshold. So you want to think about how much difference in SSD is okay before you have to call a physicist to verify that it's okay to treat the patient. Checking the chat. So what is the time period within which correction shifts should be made? Okay, so that, that's a good point about how long you're spending looking at imaging. That's another reason you might consider re-imaging. If you've taken a long time to review the image, decide what shifts to make, sometimes we'll reacquire images if it's been a long time. The patient might have moved since the image was acquired, because the images that you're matching to might have been taken 10 minutes ago. If it took a while for the physician to come to the machine, or if you spent a lot of time reviewing the images, you may want to have a repeat image right before treatment to confirm that the patient hasn't moved. So that's a very good point. Thank you. So other factors that can affect alignment. So not all offsets that we observe can be fixed with shifts. So shifting the patient a centimeter this way or that way might not fix setup issue. Sometimes patient intervention is required, or they need to be repositioned. So some of these factors would be bladder and rectum filling. That's a big one for treatments occurring in the pelvis. That can impact your prostate positioning quite a bit. There's also breathing motion that can affect positioning, weight loss or gain during treatment. After the time of simulation, the patient might have gained weight or lost weight. Sometimes this can be swelling from medication. So that can affect your SSDs and your setup. There can also be skin pressure pulling from clothing and tape. So here's an example where you see this breast shape looks different. So this one on the right was from simulation. And during simulation, the patient had a wire on their scar. And so this was like tape that was on the breast surface, and it was impacting the shape of the breast. And since that tape wasn't there for treatment, they observed that the breast shape looked a lot different for treatment than it did for simulation. So in this case, they actually ended up repeating a simulation without that tape on to match better what it looked like for treatment. Positioning of extremities can affect setup. Roll or rotation, pelvic tilt, those are things that you would want to go in and actually correct with your patient positioning on the table versus just apply a shift. And then chin position and neck extension as well, taking care to make sure that your chin isn't in the field if it wasn't there for the planning team. So here are some setup issues to look for on imaging. So unattended body parts or treatment accessories might be included in your treatment field. Here's an example where it was noted on the patient's imaging that their arm was in the field. And so it turned out that the arm was actually there for simulation. You can see the patient during the simulation, their elbows were there, but then there was a sim note, a setup note added during planning, directing the therapist to put the arms up for treatment. So the arm was not included in the body contour because they assumed it would be moved out of the way for treatment. And so the dose calculation did not include the arm's presence. And so that's a case where the alignment might be good with the ribs that are being treated, but we have an additional body part in the field that's impacting our dose calculation. So again, making sure that everything is communicated properly from simulation to planning to treatment. In this case, something changed in the planning process. They wanted to change the arm position, but that wasn't clearly communicated to the therapist. Another thing that can be helpful is adding carinas to your DRRs to verify what vertebral body you're on. It can be very difficult when you're imaging the thorax. If you don't have the full scan range to see the top of the ribs or the bottom of the ribs, it can be, you might align to the wrong level, a wrong vertebral body. So one thing that we do for all of our spine or T-spine cases, we add a contour of the carina to our DRR. And so that's kind of like a good visual cue if we're at the right level, if we see that the carina is at the right level or if it's offset, that can help prevent treating the wrong vertebral body. So here's an example comparison with DRR showing the pelvic tilt that we were talking about. So we're blending our DRR image with our image acquired on the machine. You can see that the pelvis is tilting. It's at a different tilt for treatment than it was for planning. So this is something that you would want to go in the room and help correct the patient positioning. This isn't something you can correct just with applying a shift from your imaging, an automated shift. Here's another screen capture showing a planning CT blended with a cone beam CT. And so we would blend and compare the planning image with the acquired image, and then the user would perform a manual or automatic registration process. And you'll see on the next slides, we're showing that we're aligning based on prostate and rectum matching. As I mentioned, the fill of the bladder and the rectum can really affect your prostate position. And so we'd be matching in this case to soft tissue instead of to bony anatomy. And so you might notice offsets with the bony anatomy, but the soft tissue alignment is good. And then here we see what the table shifts are after alignment of the soft tissue. And those shifts would be sent to the treatment machine to position the patient properly for treatment. I'm just letting the interpreter catch up a little bit and then taking a glance at the chat as well. So SSD threshold, at our site, we use 1.5 centimeters as our threshold for when physics should be notified to see if we need to do anything different, just kind of analyze the situation, see if the patient is set up properly and what the effect on the dose calculation will be. In some cases, that might still be appropriate for treatment, but it's different enough for us to warrant investigation. So that's the threshold we established, 1.5 cm. But that might differ depending on your site and your treatment type. Yep.
Yeah, there's also another question from Gamal. Is it okay to apply shift if acceptable now, then in later stage? At the end, we are away too much from our starting point. So when it's trying to ask if it's okay to apply shift in this sensation like that. So it's trying to ask that will it not at the end of the day be too far away from the initial starting treatment point?
I see what you're saying. Yes. So it depends on how often you're imaging, your imaging frequency. So if you're imaging every day and you're comparing your images with your reference image, every day you might have slightly different shifts. The patient might be on the table just slightly differently, but we're aligning to their we might be aligning to their bony anatomy, getting it fine-tuned. So those shifts might be a little bit different every day. And that's okay because we're trying to align to their planned position. But if we're applying a shift one day and then we're not re-imaging the next day, you want to be very careful about making sure that that shift was appropriate and that you're always being consistent. So if you notice, like if you're doing a weekly image and you're just imaging once a week and you notice that you're shifting by 1 cm, you probably want to repeat that image the next day to make sure that that correction is consistent from day to day. Make sure that the patient positioning is consistent. You wouldn't want to just apply it one day and then go back to your original position the next day. So being very careful about not applying shifts for the rest of treatment if you haven't verified that they're appropriate and consistent. But you might expect to apply slightly different shifts each day if you have daily imaging. That's helping you fine-tune your treatment position to maintain those tighter margins. When we find a shift, we change the couch position or the patient. So that depends. Like if it's just an automated shift that you can apply with the treatment couch, that would be how it would be done if it was done automatically through your IGRT system. But if you noticed a problem with like the patient roll or like the tilt of their pelvis or their chin position or something like that, that's something where you would go in and actually adjust the patient position. And in that case, you'd want to reacquire an image again to make sure that their new position is correct. But if it's using the automated system with your treatment machine, that's generally going to be moving the treatment couch to get to the right position. But that might just be, that might only give you limited options for what you can shift. So probably left, right, up and down, in and out, maybe rotation if you're allowing rotation shifts. But if you have to actually change the patient's positioning of their arm or their chin or something, then you would move the patient themselves. Okay. Reference image in the patient's X-ray, in the patient's file. How can it be relied upon when there are biological changes in cancer? Okay, so yes, their planning image was taken at the time of simulation, and there may be changes during the course of treatment because we're getting further away in time from when they were imaged for simulation. So that's something the physicians want to be aware of. You might notice that there's tumor growth during the course of treatment on the imaging, in which case they might need to have their plan adjusted. So if the physician is noting that there's changes to the tumor presentation, for example, during treatment, they may want to go back and acquire a new simulation for planning to make sure we're including all of the GTV and CTV and PTV that they want to for treatment. But the plan is based on their simulation image, and so we want to set up to that image as our reference unless we're adjusting the plan and making a change. And then we would have a new reference image. Since for setup verification are going to depend on your treatment site and the margins you're using and your imaging technology. So that's something you need to discuss with your physicists and physicians and kind of come up with a plan for each treatment site to know what's appropriate. And at the beginning, you might want to be acquiring, more imaging over subsequent days to make sure it's consistent before you maybe reduce imaging frequency to once weekly for that site, once you know what your established patterns are and how consistent your setups are from day to day. But that's definitely something to work out with the whole team when you're adding IGRT. As far as recommendations for accepted ranges for online shift correction, I don't have a publication that comes to me at top of mind. I don't know if anyone else on the call does. Okay, so we'll continue with timeout.
No, not really. I think we'll probably look it up probably after.
Okay, thank you, Benjamin. All right, timing out before treatment. This is a basic safety concept that comes from surgical procedures. So this has been implemented in surgery for the past couple of decades to reduce simple errors such as performing surgery on the wrong site, performing the wrong procedure, or treating the wrong patient. And so 2 examples are from the Joint Commission, which is a regulatory body in the United States, who has the Universal Protocol, and then the World Health Organization has the Safe Surgery Checklist, which came out in 2008. So key elements for these timeouts are a pre-procedure verification process, marking the procedure site, and then performing a standardized timeout to verify correct patient, correct site, and then the correct procedure to be done. So how this applies in radiation therapy, prior to delivering a radiation treatment, right before we turn the beam on to deliver treatment, the therapist will time out to verify the patient ID, plan ID, prescription, and then any critical parameters of the treatment technique. And definitely at the first fraction, you're going to want to have an expanded timeout where you're verifying all of the plan parameters versus the written documentation. So here again, it's important to develop a procedure for which critical items must be checked before patient treatment during your timeout. So depending on which system you're using, which kind of documentation, you might want the therapist to be checking for any alerts or journal notes or changes to prescription. It depends on your software and workflow where they should be looking for any critical updates prior to treatment each day. You can also have timeouts occurring at different time points or during different parts of the process. At our site, we have timeout that occurs in the room to confirm positioning is correct. The therapists time out together, making sure that the setup is correct, table parameters are correct, and that the shifts have been applied correctly. Then there's a separate timeout during imaging, where one therapist will say what type of imaging they're performing, and the other therapist will repeat it back. So they'll say, taking an OBI, and the other therapist will say, yes, OBI. So both confirming together about what type of imaging they're doing based on what was required by the prescription. But the main timeout that I'm talking about is directly before treatment, right before turning the beam on. There should be a timeout procedure. This looks like a very lengthy procedure, but this is just to be very detailed. So it can be used for training so that the therapists understand which key items they should be checking. In practice, it doesn't take very long to make it through these steps. There aren't that many things that they're checking, but it will be tailored to your clinical workflow and procedures being performed. And so it's important to have documentation that specifically says where to look to find these things, which items must be timed out. But definitely verifying patient identification and that you're treating with the correct plan and prescription. So that brings us to another Zoom poll. I think we may have lost Benjamin to run the poll. Let me see. So what is the purpose of performing a timeout prior to delivering radiation treatment? Are we doing this to give the therapist a break between patients? Are we checking the quality of the isodose plan? Or are we verifying critical information about the patient and treatment to prevent errors? I'll give you a few more seconds to answer. The answer's rolling out, and I'll give it a couple more seconds. So here are the results. Again, about 90% of the respondents got it right. We're wanting to verify critical information. So timeouts are designed to focus the team's attention on critical elements immediately prior to treatment to prevent major errors. Okay, real-time monitoring of treatment. So it's important to observe the patient during treatment. We want audio and visual monitoring at all times of the patient. Oops. This is necessary for safety to watch for collisions during movement of the gantry and imaging arms. And we also want to watch for any kind of patient movement that occurs after setup and imaging. So if any significant movements are observed, like severe coughing or the patient moving their body in the treatment region, you'd want to re-verify positioning. So just an image of treatment monitoring, and then an image showing a machine rotating around a patient. You can see it's critical to watch that we're not going to be close to colliding with the patient, with the treatment head, or with the imaging arms. And if you can't tell from video if it will collide or not, it's important to go in and do a collision check prior to performing the motions remotely. Therapists should also be watching the MLCs. If it's a dynamic treatment, IMRT or VMAT, you want to see that the MLCs are moving during treatment. But even for 3D treatment fields, we want to make sure that the MLCs are moving into position for each of the static fields as well. This is an example of a type of upgrade you can establish for breath hold patients, optical surface monitoring. So we have infrared cameras. This is just a graphic showing these red imaging zones, ensuring that the patient doesn't move during treatment. So this is an example of VisionRT, which is a surface monitoring software. And it's showing you if your patient's surface is moving during treatment. And this can be very helpful for breath hold treatments, for example, for breast cancer. If you're trying to treat with a deep inspiration breath hold, we want to confirm that that breath hold position is the same each day. But again, this is not a standard option. This is something that might be added to your machine, or some sites may have and others may not. But that's an example of monitoring during the patient's treatment. So I want to talk a little bit about treatment interruptions. So these can be interruptions that occur for patient reasons or for machine and power issues. So if we have patient treatment interruptions, these might be caused by anxiety or claustrophobia. So if a patient's in a tight mask or if they feel like the machine is close to them, they might have issues with anxiety or claustrophobia, and that might make it hard for them to make it through treatment. So they might, get too anxious to continue with treatment, might have an inability to hold their bladder. If you're trying to treat with a full bladder, this can be problematic for some patients. They might have to interrupt treatment to use the restroom. A patient might have pain and discomfort that causes them to move or not be able to tolerate treatment, or have a sudden illness or vomiting. So for any of these cases, if a patient issue interrupts treatment, you need to address the issue, and then you might be able to realign and resume treatment to deliver the rest of the treatment fraction. If they're not able to resume treatment, then you need to document the partial treatment and assess with the physician and physicist to decide what to do for the next day if the patient's coming back for treatment at a later time. You might also have treatment interruptions due to machine problems. So if you have a machine issue or a power issue, these might be transient issues that can be quickly resolved. And so if you just have a brief power flicker, or you have like a MLC issue that you're able to reinitialize, you might be able to resolve and resume treatment while the patient is still positioned. But if there's a more serious issue, it might require service or QA from the physicist prior to resuming treatment. So again, same as for a patient interruption, you may be able to realign and resume treatment that same day or same moment. But if you're unable to resume treatment, you'll need to document again and assess it with the physician and physicist. So there's some recent guidance that came out from AAPM. There's a task group report about fault recovery in external beam therapy. So this is detailing what everyone's role is if there is an interruption. So important things are capturing information at the time of the fault, how to return the LINAC to clinical service. And there's also some good guidance in the appendices of this report of the effective downtime on patient treatments. It has some example like EQD2 calculations if you have extended treatment breaks, and then potential responses. So moving patients to a different treatment machine or a different treatment site, how different clinics handle these types of interruptions. So that's a good resource to look at about treatment interruptions. So the first priority, if you have any kind of treatment interruption, is to ensure the safety of the patient. That's the first thing you want to do. And then you want to make sure you're recording the number of monitor units that were delivered if it was a partial treatment. You're also going to want to document any error messages. If there's an error code or some sort of warning message on the console, you want to make sure you capture that and document it. And then you may need to contact the physicist or service engineer if it's not something that the therapist is able to resolve. So this is just a picture showing a backup MU counter. So LINACs are designed so that even if they lose power during treatment, they should display how many monitor units were delivered for the last treatment field. So you want to know where to look to find this information in case you have a treatment interruption or loss of power. So this is an example for an elective machine. Here's also an example for a Varian TrueBeam machine. So knowing where to look on your machine to find that number of monitor units is important. So if you have a power or software networking problem that prevents the treatment record from being recorded, you may need to make a manual correction in the system. So anytime there's some sort of interruption that prevents the treatment history from being recorded properly, the therapist should notify the physicist to make sure they investigate and see if it was recorded properly or not. And so we want to document how many fields were fully treated, how many monitor units were delivered for partially treated fields. And then the physicist can either import the treatment record if it was saved locally. Sometimes it will save just on the local console if the networking system isn't working. Or if they can't recover that treatment record, they might be able to manually enter the treatment into the record and verify system. But very important, if it looks like something didn't record properly, or if there was some sort of interruption, to communicate with the physicist and make sure they're able to investigate and make sure that the delivered treatment was recorded properly. So if you do have if you do have a partial treatment delivered, the physicist can recreate the delivered dose in the treatment planning system if that's something that will be helpful for the physician to decide how to proceed. There's different options depending how much dose was delivered. The radiation oncologist may decide to resume the partial fraction during the next treatment day. They might decide to ignore the partial fraction. If you just delivered a few monitor units, for example, they might ignore that and deliver a full fraction the next day. So you need to take steps in the planning system to make that available. And then they might also modify the plan for remaining treatments to achieve the desired total dose. So that might be more likely if you have an extended treatment interruption, like the machine goes down for several days or a week or something. You might need to start thinking about modifying the dose if you want to make corrections to achieve the EQD2 that you want. So that brings us to another Zoom poll. Benjamin, are you able to launch the poll? I can try to launch the poll again. Okay, here's the third Zoom poll. What is the first priority in the event of a treatment interruption? Ensuring patient safety, rescheduling remaining patients that might be waiting in the waiting room, or calculating EQD2 for interrupted treatment. So key here being, what's the first priority? We'll give it a few more seconds. Okay, so majority again, about 90% of you got it right. Our first priority is definitely to ensure patient safety. The delivered MU and other relevant information should be documented and situation should be assessed. You'll need to take care of scheduling and corrections, but the very first priority is ensuring patient safety. Okay, I know we're a little bit over time. I apologize for that, but this is the last section. So we'll just go through this part and then we'll be done with today's session, address any questions. So number 8 is ongoing treatment QA and incident reporting. So weekly chart checks are another important part of QA and program management. So weekly chart checks by therapists and by physicists are important to make sure that treatment is proceeding as planned. So some of the things being checked during weekly chart checks are making sure that the dose is tracking accordingly, according to your plan and prescription. We want to make sure treatment parameters are consistent with the plan and consistent from day to day. Make sure that appropriate imaging is being acquired and approved by the radiation oncologists. And we can also look at the setup photos and shift information to make sure setup is appropriate, SSDs are within our tolerance, and any kind of treatment accessories like bolus are being applied as intended. And then making sure that treatments are recorded properly. To do this, it's important if the patient does have gaps in treatment that those things are documented and there's explanations recorded so that when a therapist or physicist comes to do a weekly chart check, they understand if the patient record didn't save or if the patient just missed treatment that day due to a known reason. And then making sure that remaining treatments are scheduled appropriately. There's also chart checks at the completion of treatment. These are similar items to weekly chart checks, making sure that the dose was delivered as intended, making sure that it was the complete dose that was prescribed, and then making sure that appropriate setup and imaging were used. And then you might have different closeout procedures for the patient chart, depending on your software and your workflow, like completing the course at the end of treatment, so it's no longer available at the treatment machine. So incident reporting, I know you had a different lecture that talked about safety and talked about some of these reporting systems, but just important to remember that despite everyone's best efforts and despite all of our training and our protocols, incidents will occur. Hopefully minor ones that we can learn from, but it's important to track these things and learn from them. So the focus should definitely be on the weakness in the system, not on individual blame. So often it's multiple individual factors that lead to an error occurring. And we want to understand where those errors happen in the process and how we can improve our processes to prevent errors in the future. So the importance of tracking incidents is to learn from our mistakes so we can improve the system. And then we want to share these lessons learned with all of the team members so that everyone is on the same page and learning from the same material. So incident reporting can be locally managed. You might have your own database that you track incidents with, or you may have an external reporting system. And then it's important to have meetings to discuss incidents so you can have feedback to improve processes. So there's different types of incident learning systems available. Definitely, you'll be reporting incidents to regulatory bodies if required by regulation. This would be for serious medical events. But there's also systems that you can use to report more minor issues where it didn't result in mistreatment of the patient, but maybe there was a good catch or a near miss or something wasn't as ideal as it could have been. And so there's databases that can track those things as well. So there's an example through Estro, one in the US for AAPM and Astro, and then Saffron, which is hosted by the IAEA. So that might be a good tracking system to use if you're affiliated with the IAEA and have a Nucleus account. So there's been a review of major sources of errors from Royals, which is in the US. And so they found that of the incidents reported, there were 3 major categories. So problems with the plan that was approved for treatment, wrong shift instructions given to the therapist, or wrong shifts performed at treatment. And so these errors were discovered at different times during the process by staff or even by the patient questioning the staff if they noticed that their treatment delivery was different one day from other days, or if their setup, was different than it was during their simulation. So shift errors can come from the wrong instructions or wrong reference points being used or using the wrong reference CT for image guidance. And then wrong shift applied could come from having poor alignment of the cone beam with the reference CT, or making adjustments or changes after the first treatment and not recording those changes, or errors in manual shifts instead of using automated shifts. So there's a lot of different ways these errors can happen. That's why it's important to track them and make sure we learn from them to prevent them from happening again. So to prevent errors in treatment delivery, some of the key aspects are having physician peer review of your targets, understanding that manual processes can create errors, especially when you're recording shifts manually. Doing timeouts for patients each day can help reduce some of the major sources of error. And then understand that your standard physics and therapist checks might not catch all errors. So it's important for everyone on the team to be vigilant and aware that things can arise at any point in the process. And the most serious errors would affect the entire treatment. So having the wrong target definition or wrong reference images could affect the patient's whole course of treatment, not just one day. So some take-home points from today's lecture. A safe treatment delivery for our patients depends on a robust quality management program. So this starts well before the patient arrives for treatment with physics checks, therapist checks, high quality plans that have been peer reviewed, etc. It's also important to confirm patient ID and perform timeouts. These are simple and effective ways to reduce treatment errors, things that you can do for every patient every day that will help minimize your errors. Very important that setup information is documented thoroughly and communicated clearly from simulation to planning to treatment. That's very important to ensure consistent treatment with what was planned in the treatment planning system. And then understanding that imaging plays an important part in reducing setup uncertainties, so that we can have smaller margins like we use for 3D conformal radiation therapy compared to 2D. Another take-home point is understanding that treatment interruptions may occur, and we must have a process for documenting them and assessing them. And then it's important also to have ongoing treatment QA and incident reporting to help us all maintain a high standard of care and reduce errors. So with that, I'd like to thank everyone for your time and attention. Again, I'm sorry for going a little bit over the time.